Shock is inadequate blood flow to the body tissues. Shock can have many causes, but on the battlefield, it is typically caused by severe blood loss. Hemorrhagic shock is a leading cause of preventable death on the battlefield. The normal adult blood volume is 5 liters. 500 milliliters of blood loss is when you donate a unit of blood at the blood bank. Physiology is normal, and there's no danger from this level of blood loss. After 1,000 milliliters of blood loss, the only sign may be a slightly elevated heart rate. After 1,500 milliliters of blood loss, symptoms may include anxiety, weak pulse, elevated heart rate, low blood pressure, and increased respirations. But still, the casualty is not likely to die from this. 2 liters of blood loss likely represents ongoing, uncontrolled hemorrhage. The casualty may be lethargic with a weak pulse, elevated heart rate, low blood pressure, and rapid respirations. At this point, it is quite possible they may die from blood loss. This is hemorrhagic or hypovolemic shock. With continued blood loss, the casualty has now lost 2,500 milliliters, or half of the blood in his or her body. This level of hemorrhage is likely to be fatal. Your job is to not let them lose this much blood. Remember, the most reliable signs of shock on the battlefield are a decreased level of consciousness without TBI and/or a weak or absent radial pulse. If signs of shock are present, control the bleeding first. Hemorrhage control takes precedence over infusion of fluids. Not all casualties need IVs. Do not start IVs on casualties who are unlikely to need fluid resuscitation or IV medications. Do not use for minor injuries as it wastes supplies, takes too much time, and can distract from other more important care or tactical concerns. The indications for IV access are fluid resuscitation for hemorrhagic shock or significant risk of shock such as GSW to the torso. The need to give medications, but the casualty is unable to swallow, is vomiting, or has a decreased level of consciousness. A single 18-gauge catheter is recommended for access. Don't insert an IV distal to a significant wound. A saline lock is recommended instead of an IV line, unless fluids are needed immediately. Flush saline lock with 5 cc's normal saline immediately, and then every 1 to 2 hours to keep it open. If unable to start an IV and fluids or meds are needed urgently, insert an interosseous line. Tranexamic acid, or TXA, helps to reduce blood loss from internal hemorrhage sites that can't be addressed by tourniquets and hemostatic dressings. Tourniquets and combat gauze do not work for internal bleeding. TXA does. TXA is indicated if a casualty is anticipated to need significant blood transfusion. For example, hemorrhagic shock, 1 or more major amputations, penetrating torso trauma, or evidence of severe bleeding. Also, TXA has been shown to improve mortality and morbidity in patients with traumatic brain injury, TBI, or head trauma. 2 grams of tranexamic acid should be administered via slow IV or IO push as soon as possible, but not later than 3 hours after injury if it was not previously administered. Survival benefit of TXA is greatest when given within 1 hour of injury. Give it as soon after wounding as possible, but do not give TXA if more than 3 hours have passed. Possible side effects of TXA include nausea, vomiting, diarrhea, and visual disturbances. Do not be deterred by possible side effects. The important thing is to stop the bleeding and save the casualty's life. In summary, assess for shock and establish IV or IO access after external hemorrhage is controlled. If indicated, give TXA as soon as possible and before 3 hours.